Brown Physio. So today in this video we're gonna study about dislocation of shoulder. So there are three types of dislocation of shoulder: anterior, posterior and inferior. Anterior is the most commonest. Posterior is mostly seen in the cases of electric shock and anterior trauma. Inferior is the rarest, and also it is known by these two following names. Now let's see about anterior dislocation. The mechanism of action for the anterior dislocation is directly blow on the posterior aspect of the shoulder, then fall on the outstretched hand in the lateral rotation. You have to remember all this. Usually when a fall on outstretched hand is in lateral rotation, the head of humerus is thrust against the tightened anterior capsule, which gets toned or pulled, that is avulsed from the anterior rim of glenoid. The anterior dislocation also has three subtypes, that is preglenoid, subcoracoid and infraclavicular, which is also known as subclavicular. We gonna see this with the diagram to understand in a better way. As you can see, this is clavicle, this is scapula, and this is the normal position of the humerus with relation to the scapula and clavicle. So A, which is preglenoid, the humeral head lies in front of the glenoid. Then B is subcoracoid, the humeral head lies below the coracoid process. Then C, which is infraclavicular or subclavicular, the humeral head lies below the clavicle. So clinical features are E, inability to move the affected shoulder. Then when a patient with dislocation of shoulder, how you can see him or her visiting in the clinic is that the patient is supporting the injured limb by the other hand. Then deltoid flattening. What is deltoid flattening? So this is the normal structure, how normal deltoid muscle can be seen. There is fullness over here in the shoulder. Usually when there is dislocation of shoulder, the fullness of the deltoid muscle is lost. Okay, this is known as deltoid muscle flattening. Fullness below the clavicle due to displaced head can be felt by rotating arm. Deltoid muscle paralysis if axillary nerve damage can be there. Normal contour of shoulder is lost. Then investigation, either we can do X-ray or MRI. In MRI, we can see Bankart lesion, heel such lesion or rounding of anterior glenoid, and in X-ray we also have to take through axillary view. Now there are some special tests which can be done to diagnose the dislocation of shoulder. These are the special tests which we have already studied in our third year, so I'm not going much in detail. I'm just letting you know the name. If you want to read about this, you can pause the video and read about it, how to do this test and what is the positive diagnosis. First is Dugas test, second is Hamilton ruler test. Then for the treatment, close reduction is done through Kocher method, Hippocrates method or Stimson method. These are the medical management. It is not asked much, as mostly physiotherapy management is asked, but you should know all these three topics, that how it is done. Again over here I have mentioned in very detailed manner and in very simplified manner that how these methods are done to treat dislocation of shoulder. You can pause the video and read, and if you cannot understand anything, do let me know in the comment section. This is the second method, Hippocrates method, and this is the third, Stimson's method. Now coming to our main role, physiotherapy management. Our rehabilitation goal should be to gain back the functional range, to restore normal muscle strength, to regain full shoulder range of motion, especially of abduction and external rotation, and for pain relief. Now conservative treatment, that is immobilization phase, which is of first 3 weeks. Arm is strapped to the trunk in position of adduction and internal rotation. Wrist, finger and which are left free. Full resistive movement of this joint should be practiced. Isometric exercise for deltoid, biceps, triceps should be done. Then for pain relief, icing and TENS should be used. Then mobilization phase after 3 weeks. After removal of strapping, the limb is supported in a sling. Elbow should be mobilized to full extent gradually by removing the sling. Mobilization of shoulder should be done in above following manner. First, flexion extension. Shoulder flexion extension should be initiated as small range pendulum swinging movement in the forward stoop position. Sling be loosened to achieve greater range of motion. Second, abduction and external rotation. These are two movements main cause of redislocation. So you have to do this movement very carefully. They have to be initiated with utmost care and adequate stabilization of glenohumeral joint. Relax passive movement. That if you want to achieve abduction, then adduction plus internal rotation to 45 degrees should be done, and to achieve external rotation, adduction plus external rotation should be done. To avoid adhesive capsulitis, heat therapy for pain relief. Once good passive range is achieved, should plan for strengthening exercise by self-resistive isometric isotonic. After 12 weeks of injury, patient recover and carry on with heavy exercise, passive stretching, abduction and external rotation. Now let's see what all can be the complication for the anterior dislocation of shoulder. So adhesive capsulitis, which is also known as frozen shoulder, then fracture of greater tuberosity or surgical neck of humerus, then supraspinatus tendinitis, rotator cuff injury, redislocation, that is recurrent anterior dislocation of shoulder, injury of axillary nerve during reduction. All these complications should be detected as earliest. Now let's move on to posterior dislocation. Posterior dislocation mechanism of injury is directly blow on the front of the shoulder, that is anterior of the shoulder, with arm in internal rotation. So in anterior dislocation of shoulder and posterior dislocation of shoulder, what is the difference? Over here blow is on the posterior aspect, over here blow is on the anterior aspect. Then push with external rotation, over here it is internal rotation. Then treatment is, fresh dislocation is treated by manipulative reduction. Rest physiotherapy is same as the anterior dislocation of shoulder. Inferior dislocation, it is a rarest case when limb is strongly abducted. For example, holding a branch of a tree with the arms in a wide abduction while falling down from tree. As a result of this injury, the head of humerus is pushed down underneath the glenoid. The arm is held fixed in the wide abduction elevation utmost by the side of the head. This type of dislocation is termed as flexio erecta.